So good afternoon, everybody. Today we'll start with anti-diabetic agents. So first I'll start with OHAs. So before that I'll give an introduction about the beta cell and all that, the insulin, the normal physiology. So basically we have pancreas. So pancreas is called as heterocrine gland because it works as both hexocrine as well as endocrine gland. So the exocrine gland is made up of the pancreas. Imagine pancreas is there, and that is made up of 99% of acini. So the acini, okay. So that is the exocrine part. Exocrine part is made up of acini, so that is responsible for the production of pancreatic juice, and the endocrine part is made up of islets of Langerhans. So that is being divided into 4 types, that is alpha cell, beta cell, gamma cells, and the alpha cells, beta cells, delta cells, and the gamma cells. So in that, alpha cells is known to produce glucagon. The beta cells is known to produce insulin. Okay, so basically that is the endocrine part. So coming to alpha cells, that is glucagon, and beta cells is insulin. Okay, so now we learn about beta cells. Okay, so imagine you have a beta cell. So within the nucleus, a gene undergoes transcription to generate mRNA. Okay, so this mRNA is released into the cytoplasm. Okay, this mRNA undergoes, the gene undergoes transcription to release mRNA. This is released into the cytoplasm. In the cytoplasm, it enters the ribosomes. Okay, so once it enters the ribosomes, it undergoes translation, resulting in the development of resulting in the production of protein. Okay, translation is basically protein synthesis, resulting in protein. So this protein is called as pre-pro-insulinemia. Pre-pro-insulin. Okay. This is called as pre-pro-insulin. Okay. So now this pre-pro-insulin, that is this protein, it enters into your rough endoplasmic reticulum. Okay. In the rough endoplasmic reticulum, it undergoes all the modifications and it results in the formation of pro-insulin. Okay. And this pro-insulin enters the Golgi apparatus. And in Golgi apparatus, it undergoes packaging, resulting in the formation of insulin vesicles. Insulin vesicles, like I told you, it will undergo package, right? So it will be packed, okay? And in this packaged form, it will have insulin plus C peptide, okay? So this packages is there in your cell, inside your beta cell, okay? Now here, what happened? Imagine, okay, this beta cell has a transporter. So this beta cell is having this GLUT2, okay? So this is a transporter. This transporter is called as GLUT2, that is glucose transporter. So this transport glucose inside the cell. So imagine your blood is having high amount of glucose, that is after your food. So this glucose enters via this GLUT2. So this GLUT2, there is 2 types of important transporter, that is GLUT2 and GLUT4. So GLUT2 is independent of insulin, whereas GLUT4 is dependent on insulin. I'll tell you that why it is important. So now GLUT2 is independent of insulin. So imagine your glucose is entering inside the cell. This undergoes the process called as glycolysis, you know all that, right? So all that glucose 6-phosphatase and all that, finally it results in the formation of pyruvate, okay? So this pyruvate enters into your Krebs cycle, that is TCA cycle, and it results in the formation of all this NADH, all that. So this NADH enters into your mitochondria. Enters into the mitochondria, and it results in the formation of, and finally it undergoes all this electron transport chain and results in the formation of ATP. Okay, so now ATP is there in a cell. So we have a potassium channel here. The beta cell is having a potassium channel. So this ATP comes and binds to this potassium channel. Okay, once it binds, this potassium channel is closed. So there is high accumulation of potassium within the cell. Okay, that is the intracellular potassium keeps increasing. So this is known to result in the increase the membrane potential, positive membrane potential. Okay, so this in turn, there is another channel simultaneously, that is called as calcium channel. This increase in the potassium levels, that is high polarization, all that, it is known to cause, it will open the calcium channel. Okay, so this will result in the entry of calcium channel into the beta cells. So what happens, this calcium channel goes and attaches to this vesicle. Okay, once it attaches, what it does is, this will go and attach here, right? So this will help in the opening of this cell membrane. Basically this will open. Okay, that is what I'm trying to tell is, see, this is your beta cell, right? So imagine your calcium is coming and it is opening this as well as this, and it will join this. So because of this, your insulin and your C-peptide is getting released into the bloodstream. Understood? So this is how insulin is formed, and this is how insulin is released into the bloodstream. Okay. Imagine now your insulin is in your bloodstream. This is the bloodstream and insulin is there. So what happened? It goes to the liver. Insulin goes to the liver. So now here again the liver is having GLUT2. Okay, that is glucose transporter, and the liver has a enzyme. It has a receptor. This is called as insulin receptor. It can be also it is called as phosphothyrokinase 3 or AK3. The receptor name is that. Just remember insulin receptor. Okay. So what happened once this insulin is in the bloodstream, and you have food also. You have food. So through this glucose is entering into the bloodstream. Okay. So now this insulin which is which is there in your bloodstream, it goes and attaches to this insulin receptor. So because of this in turn promotes the conversion of glucose to glycolysis. Same, it will undergo the same mechanism, or it will go to pyruvate, then it will go to TCA cycle, then it will finally result in the development of ATP. So one, glucose is getting transported, so with the help of insulin. Second, it will help in the conversion of glucose to glucagon. Okay, so basically glucose is getting converted to other forms. First, it will get converted to ATP. Second, it will get converted to glucagon with the help of insulin. Okay, so in the liver, two things are happening. First is glycolysis and glucogenesis, formation of glucagon, right? So glucogenesis in the liver. Then you have your skeletal muscles. So in skeletal muscle, we have the channel called as GLUT4. Okay, I told you initially GLUT4 is insulin dependent. So what happens is, this is having insulin receptor. This is having the insulin receptor. The same insulin receptor. Even this is having. So only if insulin comes and attaches to this receptor, this GLUT4 can open. Okay, only if that GLUT4 open, the glucose can enter inside. So that is what I meant by insulin dependent. Whereas here, even if insulin doesn't come and attach, glucose can enter inside. Whereas only here, if the insulin comes and attach, this in turn stimulates this GLUT4. Only then glucose enters. Okay. So once glucose enters into the skeletal muscle, again it will get converted to ATP, will undergo glycolysis, and it will get converted to ATP. And there is another. What happens is this. There is amino acids. Okay, this insulin promotes the conversion of amino acid to peptide bonds, which finally results in the formation of proteins. Okay, so basically two processes inside the skeletal muscles. One is ATP production, that is glycolysis. First important thing is it will help in the intake of glucose. Second is it will help in the production of ATP. Third is it will help in the formation of protein synthesis. Okay, so that is the thing when it comes to skeletal muscles. So first liver is done, skeletal muscle is done. Next we have adipose tissue. It goes into the adipose tissue. Okay. Again, adipose tissue is having GLUT4. So what is GLUT4? It is insulin dependent. So insulin will come and attach to the receptor, and this in turn stimulates the entry of glucose. Stimulates GLUT4. So this in turn opens up and helps in the entry of glucose into the adipose tissue. So in adipose tissue, glucose gets converted to two forms. Okay, that is DHA4, that is dihydroxyacetyl phosphate, and glyceryl 3-phosphate. Okay, glyceryl 3-phosphate. Finally, this gets converted to these two gets converted to different forms and finally results in the formation of triglycerides. Okay, so basically we have lipogenesis. Okay, so the different forms of what is the different functions of insulin, if you ask me? First is, in liver it will help in glucogenesis and glycolysis. In skeletal muscle it will help in glycolysis and protein synthesis. And in adipose tissue it will help in the formation of lipids, that is lipogenesis. So this is the basic physiology of insulin in your body. So now coming to OHAs, that is the anti-diabetic oral hypoglycemic agents, that is OHAs, oral hypoglycemic agents. So this is the different types. First we have biguanides, that is metformin, sulfonylurea. Okay, I'll go class wise. So biguanides, that is metformin. So what metformin does is, metformin is called as, so again these can be divided into two types, that is insulin sensitizers and insulin secretagogues. Okay, insulin sensitizers are the one which causes these parts to get which increases the uptake of insulin and thereby conversion of all this. So that is called as sensitizes. That is, it is telling the organs to take up insulin and do your function. So that is sensitizes. That is insulin secretagogues is the one which helps in the formation of all this, the release of insulin. They are called as secretagogues, that is secreting, insulin secretagogues. Whereas this is insulin sensitizes, okay. So in this, biguanides, that is metformin, and thiazolidinediones, that is pioglitazone, rosiglitazones, they act as insulin sensitizers. Whereas all the others act as insulin secretagogues, okay. So now I'll go individually with the mechanism of action of each. So first is biguanides, metformin. So metformin has action at two places. That is, first, its major mechanism of action is in the liver. Second, the second action is in the intestine. Okay. So first, in the liver, it goes and it will increase the sensitivity of insulin receptors, thereby increases the uptake and thereby results in the formation of conversion of glucose to ATP and conversion of glucose to glucagon. That is the mechanism of action of metformin. Then in the intestine, what it does is it will prevent the insulin absorption. I mean, it will prevent the glucose absorption within the intestine. Okay, so that is the second mechanism of action of metformin. Okay, so the major mechanism of action is it will sensitize the liver. Next, sulfonylureas. So we have two generations for sulfonylureas. First is first generation is tolbutamide, acetohexamine, and glimepiride, and the second generation is repaglinide and natiglinide. I'm sorry. Second generation is glimepiride and gliclazide. Okay. So what we use more is second generation because first generation is known to have high risk of hypoglycemia. Okay. So among all these OHAs, the drug which is known to have high risk of hypoglycemia is glimepiride. Okay. So when compared to everything. So in this, first generation was known to have high incidence of hypoglycemia. That is why which resulted in the development of second generation things. That is glimepiride and gliclazide. So the mechanism of action of this is what sulfonylureas does is it the beta cells, it will have something called as SUR. Okay, that is sulfonylurea receptor. Okay, SUR. So the beta cells contain something called as SUR. So this sulfonylureas comes and stimulates this SUR, which in turn stimulates the potassium. I told you this potassium will come and bind it'll increase once the ATP comes and attaches, it will increase the polarization within that, and will in turn cause the calcium to enter, and which in turn can cause the opening of insulin. No? So that is the mechanism of action of sulfonylureas. What it does is it stimulates this channel, which in turn stimulates the increased potassium production within the beta cells, which in turn causes increased calcium production, which in turn helps in the release of insulin. So that is insulin secretagogues. Okay, that is sulfonylureas. Next is meglitinides, that is repaglinide and natiglinide. So meglitinide is again called as non-sulfonylureas. That means it is having the same mechanism of action as sulfonylureas, but then it doesn't attach to this receptor. So it doesn't attach to this receptor. It attaches to another receptor within the beta cells, and in turn stimulates calcium production, potassium production, calcium, and all this. Okay, so that is meglitinides. So indirectly speaking, it increases the insulin production again. So it will come and attach to a site other than the sulfonylurea binding site. And then it will increase the potassium levels within the beta cells, which in turn increases the polarization, which in turn increases the calcium release of insulin into the bloodstream. And thereby all these actions it does. Next, thiazolidinediones. So this is also called as PPAR gamma agonist. Okay, PPAR gamma agonist. So we have two types. That is PPAR gamma and PPAR delta. Okay, we have PPAR gamma and PPAR delta. So PPAR alpha and PPAR gamma. Okay, so PPAR alpha is we have drugs like that comes under anti-hyperlipidemic. So we have anti-hyperlipidemics, phenofibrates and all, you know that, right? So that is PPAR, that is anti-hyperlipidemic. So PPAR gamma is this one, okay? So what it does is this thiazolidinediones increases it stimulates the PPAR, receptors which is present, which in turn it undergoes all this translation and all that. So this PPAR receptor is present in the adipose tissue, it is present in the liver and the skeletal muscles. So this undergoes all this translation and will increase the sensitivity of all this insulin receptors. So that is why I told you these are sensitizers again. Okay, so this PPAR is known to undergo all this, it'll undergo all this transcription, translation and all, and in turn it increases the sensitivity of insulin receptors. So this in turn helps in the conversion of glucose to other forms. So that is how your blood sugar levels comes down. Okay, that is thiazolidinediones. Next is alpha glucosidase inhibitors. Okay, so we have something called as we have an enzyme called as alpha glucosidase. So this enzyme is present within the brush border cells of your intestine. So this intestine takes up the sugars. Like once your it is an enzyme. So this cleaves. You have this complex sugars. So this cleaves this alpha glucosidase. This cleaves the complex sugar to simple sugar, which in turn causes so this sugars which has been absorbed into the bloodstream by our intestine. So what happens? This drug inhibits this enzyme. So when this enzyme has been inhibited, the complex sugars doesn't get converted to simple sugars. If it is not converted, it won't get absorbed into your bloodstream. Okay, thereby it decreases the blood glucose levels. So that is alpha glucosidase inhibitors. That is acarbose and voglibose. That is why this should be given before food, because that should be given before food, because because it helps in the conversion of complex to simple forms. Okay. Next is SGLT2 inhibitor. Okay, so within the PCT, that is the proximal convoluted tubules of your kidneys, it is known to have some channel called as sodium glucose co-transporter. Okay, so this is known to cause the reabsorption of sodium and glucose into the PCT. Okay, so when you give this drug, it inhibits that channel. So because of that, the reabsorption of sodium and glucose has been prevented. Okay, in turn it results in the excretion. Okay, so that is how your blood sugar, your blood glucose levels comes down. Understood? So that is why incidence of UTI is more, because the glucose is getting excreted through your through your urinary tract. That is why. Next, coming to GLP agonist and DPP4. So these two are similar in action. Okay, I'll tell you. So we have something called as incretin. Okay, this is also called as GLP-1. That is glucagon-like peptide. Okay, so this is released into your intestine once you take food. So this will stimulate the beta. This GLP-1 will stimulate your beta cells. Once it stimulates the beta cells, it will increase the insulin production and all this action will happen. So that is why it's called as GLP agonist. That is, it will stimulate. Okay, once this has been stimulated, once you take food, this has been stimulated, and this in turn will go and stimulate the beta cells, and all this, it will help in the production of insulin and all this mechanism of action you can find. So when you give GLP agonist, it's going and increasing, it is going and stimulating more, and this in turn is stimulating the beta cells, which helps in the production of insulin and all these action. Okay, then we have something called as DPP4 inhibitor. Okay, that is dipeptidyl peptidase inhibitor. So this incretin, okay, imagine at normal condition, you can't have more of incretin, right? Because it can result in hypoglycemia, like when it becomes excess. So this incretin gets converted to an inactive form of incretin. Okay, for this we need an enzyme called as dipeptidyl peptidase enzyme. Understood? So that is why when you give DPP4 inhibitor, that is dipeptidyl peptidase 4 inhibitors, this enzyme has been inhibited. So GLP is not getting converted to inactive form. If it is not getting converted, this GLP will continue its action. That is, it will go and stimulate the beta cells, insulin will be produced, and all this action will be continued. So that is why I said you these two are interrelated. Okay, GLP-1 agonist and DPP4 inhibitors. So this is an overall idea about the OHAs. So you want me to tell the doses, like to what extent it reduces? Okay, I'll tell you the common side effects with each. So coming to biguanides, that is metformin, the common side effect is lactic acidosis and vitamin B12 deficiency. So basically, vitamin B12 deficiencies is something which you see at an early stage, and lactic acidosis is something which you see at the later stage. So why it goes to lactic acidosis is because I told you it is an insulin sensitizers, right? So ATP has been produced. So this ATP, instead of getting into the aerobic respiration, it enters into the anaerobic respiration. I mean anaerobic metabolism. So because of that, there is production of that pyruvate gets converted to lactic, and which can, in case of renal failure patients, this lactic can get accumulated, and which can result in lactic acidosis. So that is one mechanism. Okay. Next, coming to sulfonylureas. So the common side effect is, like I told you, hypoglycemia. Then, okay, I'll tell you the common. Okay, imagine now. These are the normal actions, right? When you are giving more of insulin, what is going to happen? Lipogenesis. So that means increased fatty triglycerides, so which results in weight gain. then increase protein synthesis, like in excess I'm telling. And since all the potassium is getting concentrated within the cells, it can result in hypokalemia. So that is why you give insulin in the treatment of hyperkalemia, because it'll shift the potassium from extracellular site to the intracellular site. Okay, so the side effect is hypokalemia, then weight gain, and it can result in increased acidosis and all that. Okay, so coming to sulfonylureas, because it is insulin secretagogues, right? So it is secreting more of insulin. So it is enhancing all these actions. So it can result in hypoglycemia, weight gain, weight gain. Next, coming to meglitinides, same hypoglycemia and weight gain. Thiazolidinediones, it can cause again weight gains. Okay, majorly most of them will cause weight gains and hypoglycemia. Okay, the incidence is more when it comes to sulfonylureas. Then in terms of SGLT2, it is known to cause more of UTI. So among these, all these different types, DAPA, CANA, empagliflozin, DAPA is known to have high incidence of UTI. Okay, so that is why close monitoring is required and all that.